Okay.
All those in favor, aye.
Aye.
Any opposed?
There's no one
Okay,
there.
all right. Okay, then I would ask for a motion to adjourn or to close the district meeting. Aye.
Aye.
Okay. District meeting's closed, and we can go back to the hospital board meeting.
Reconvene the, with a quorum of the hospital board meeting. Since you did such a nice job on that resolution, would you like to do it for the,
Okay.
for the rest of us?
All right, I think.
You could just say do the same motion except add 2 signers.
Yeah.
Yeah, I agree. It would be the same motion. We need to add 2 additional signers. That would be Amy Farris as a director, Lloyd Villett as a director, in addition to the others already authorized under the district.
Second, okay. All in favor?
Aye.
Any opposed? Okay, resolution passed. And we'll get that, well, do you have an official one for us to sign? Is that paperwork ready?
Actually, if you can stop at the bank after this meeting.
Well, I think they'll be closed.
Oh.
I'm sorry, I think
The
they'll be
rate
closed.
we're going,
That's why I threw that if. I threw that if in the
I know, I'm pretty sure they'll be closed by the time we're done.
I already
I'm
told
sorry.
them they might happen.
Okay, let's move on to our quality report.
So this will be quick. Amy, I think you should probably start with the colorful document that looks like this. The title of it is Mineral Community Hospital Dashboard Report Fiscal Year 2013. Draw your attention to the lower third of the page. I think that's what we should focus on. The members would just take a look at the risk management indicators. And John, will you look at the other page? There you go.
Yeah.
And are there any, beginning with inpatients who rate MCH service at 9 or 10 on down, are there any numbers there that cause concern for you or you need clarification?
Yeah, the ones that are not green.
Which one would you like to start with?
Let's
Amy?
start with the number of patients who return to the emergency department within 72 hours, because that one is above what I've seen in a long time.
Okay. So that's exactly what it is. How Mineral Community Hospital handles those is I ask for a report every month by name of the patients who return to the emergency department within 72 hours. Then I ask the medical records department for a complete copy of the 2 medical records associated with those 2 stays. And I prepare a case for our internal peer review committee. And I present that case to the internal peer review committee, where they judge the provider's quality of care on the first stay and then the return. And what they're always looking for is, did we miss something? And they vote on that. That's confidential information. They may take it to, they may find that the provider's performance was completely appropriate on the first case, and on the second case, they might take it to the extent that they find something wrong with the care that the provider delivered. They may ask it for the case to go to external peer review. Might require that the chief of staff meet with a particular provider and counsel that provider. There may be remedial training required. There's a gamut of what that internal peer review committee could find. And that internal peer review committee is made up of all of the members of the medical staff as a whole. And so you'll have physician's assistants working to find, to review a case on an MD or a DO. They're very open about it. We go out of a review of a case like that, identifying the opportunities for improvement, the changes that have to be made. And so I just want you to know that every one of those cases on the return to the ER are reviewed by the entire medical staff through a confidential peer review process.
Have we had any that have gone to external peer review?
No. And you'll find the most common thing that happens, you might have someone with a patient presenting to the emergency department complaining of a migraine headache, and the provider will care for that patient, and the patient's migraine headache pain will be relieved. And the provider will write on his discharge instructions what he would like that patient to do, and it might include a follow-up visit at the health center the following day. But the provider will usually say, if your headache pain returns, please return to the emergency department, and then we'll pick up with care there. It's reasonable to expect that some patients will return to the emergency department. It's what they should do. I think at least Dr. Smith could probably talk a little bit about that. It's not.
You don't have much control over that. I think your statement about the quality of care and it's really a standard of care for the physician. That standard of care is upheld. That's the main thing. People are gonna come back to emergency room for these issues, so you can't control that. But you wanna make sure that your providers are following the standard of care, and that that's not the reason they return.
Well put. So that's what that one's about.
Does the board have other questions? False causing harm? There was one.
There was one.
And the readmitted within 30 days. Now, I understand that that requirement isn't necessarily linked to the same condition?
Yes, it is.
Or is it? Okay, because it seemed like at one point it wasn't linked, and then,
Right.
I mean, just clarification on that.
Nationally, it's not. CMS doesn't care why the patient was readmitted. It's no longer for same or similar diagnosis, which doesn't make a lot of sense, but Mineral Community Hospital, we're looking at it for same or similar diagnosis.
Okay, so this would be for a same or a similar,
Mhm.
okay.
Yeah,
But
and they're typically.
The emergency room visits were way up, right? In July,
Yeah.
Mhm.
so there was, just one more patient that came in with that high of an increase in the emergency room. I would think you would expect a number to be higher when you had that many more emergency room visits.
We're having a hard time settling on what our benchmark really should be.
Yeah.
Gary sits on the clinical outcomes committee who oversees our trends in both of those two stats. And really, I guess zero's the benchmark, but you know you're gonna have them.
Yeah.
Healthcare.
Small enough numbers, it's hard to
Yeah.
know where you should be. I mean, well, you should be at 0, but what's reasonable, I don't know.
Especially when you're dealing with chronic disease.
Yeah.
So I wanted to tell you that we peer review 100% of the 30-day readmissions as well. It's the same process.
Okay.
We're looking for, do we have providers who have not followed the standard of care and perhaps discharged a patient before they were ready? Maybe we didn't have all of the transition established for that patient. We didn't recognize that they had dropped so far below their baseline that maybe they could have benefited from 5 days in the hospital with some physical therapy. Maybe we didn't correct their fluid overload before they sent them home, and they came back 2 days later or something like that. Those are the types of things that the peer review committee is looking for.
Are there any other questions for Kirsten? Because I think the first one, inpatients who rate MCH service 9 or 10, I think, because our next item is the customer satisfaction committee report, I think that falls under that. So
Okay.
if we could go on to that next item.
We've had 2 meetings thus far. It's a hospital-wide committee, and we are trying to draw together all the surveys that go out to different patients right now. We've had one go out from dietary and from radiology and others, and we're looking at that. We want to make it scientific though as well and anonymous. And so we may not be able to do them ourselves because of the anonymous part of it. And we're looking at all those questions. The committee is working well together. We're also looking at to keep our customers happy, we need to have happy employees. So we're looking at that side of it as well, what we can do on that side. And we're making good progress. We're meeting weekly right now to get on top of things and to make quick progress. And so every Wednesday, we're meeting for an hour. And it's been very positive, and progress has been very good. The staffer for the committee is Tanai Sirkand, who is our new BHIS person, and he was here earlier.
He's right there.
Oh, he's here, okay. And he has a master's in health administration from Washington State University, and he just finished that, and he came to us, and we're very happy to have him. So let me, well, he's our staffer, he'll help us write the questions to get them to be scientific. And we may end up going outside to hire a firm to do that, but we're concerned about the $19,000 to $16,000 a year cost. So we might do it ourselves for a while to get a feel, and then go to that one day as we go down the road. But we have enough to do right now to put it together and to work with the employees and their satisfaction as well. And we're talking about training them in customer care and satisfaction, and saying hello to people who are here in the hospital who they don't know, asking them if we can help them, just different things, and getting into some training programs would be very helpful and increase the morale and how we respond to patients and to each other in the hospital. So we're looking at both sides right now. And it's a very positive experience, and we'd love to have a board member come once in a while.
I thought we had a board member on that committee.
Well, it's to the clinical, but if we can have somebody come, that'd be great.
No, we had a board member.
Patient satisfaction?
Yes.
That'd be good.
I think
We
that
did,
was me.
I think it was Carol.
Oh, Carol.
Yeah,
Oh,
I'm pretty
good,
sure it was
good.
Carol.
We'll call you.
Carol was on both the,
Oh, that's right.
she was
I'm
on the
s-
marketing
I'm
one
sorry,
and
I'll
the
call you.
patient satisfaction.
We normally have them at 8 o'clock on Wednesdays, if that'll work with you.
That will.
Love to have you come and give us a perspective of, I'm out there in the community, this is what's going on, this is what I hear. It'll help us,
Okay,
because you can help be our eyes and ears, as the board is now. That's
Okay.
really eyes and ears to the community.
Well, and,
So, and the people who came today are obviously eyes and ears to the community as well. They're interested enough to be here, and that's very appreciated.
8 o'clock on Wednesday mornings.
Wednesday.
So, yeah,
Yes.
I'd like to start seeing some information coming out of it.
Okay, okay.
I think Kristen has done a great job at kind of jump-starting the whole,
Yes.
patient satisfaction
And
survey
Kirsten
thing.
is on the
Yes.
committee as well, and
Yeah.
very helpful, knowledgeable as well.
So, let's move on. We can have maybe an official,
Yes.
an official introduction of Tanai.
Tonight, could you
Just sneak into the corner stand.
let us know your background a little bit?
I'm sure. My name's Tanai Surkar. I'm actually born and raised in India, Mumbai, India. I have an undergrad in pharmaceutical sciences, and I have a master's in health administration from Washington State University in Spokane. I also have a green belt in Lean Six Sigma, which is probably the reason they hired me. Just putting it out there. I'm here for process improvement, quality improvement, trying to reduce the overall cost of the hospital, if that's an option. That'll come later. My priority now is quality of care after listening to everything that's supposed to be the focus, and I'll make that the focus. Process improvement is something I'm trained in. Even the best hospitals have a lot of room for improvement. Mineral definitely has room for improvement. I've seen some things, but I have a method to my madness, so I'd like to quantify things and then get it on that. Kids and the staff is extremely knowledgeable, extremely experienced, extremely helpful. So I think I can get on this quickly. Yeah, I hope to get on this, get the wheels moving in the next month or two. Just for me to get used to how things work. Yeah. Thank you.
Thanks,
Thank
man.
you, Tanai.
Tanai is great to work with. He's fun. He's exciting. And also, he is our representative to the hospital and works through the grant, the Innovations grant. And so
Thank you.
as we pay him, then we go to Innovations and they reimburse us for that. So it's a net, it's a win-win all the way around, and especially it's a win because of who he is and how he comes across.
I'm a freebie.
No,
A
in,
couple of months later, it changed.
in essence, I actually pay the hospital to work here because I pay for the cafeteria every day.
We're making money off of
I mean,
that.
All right.
Wait a minute, is
Thank
the
you,
cafeteria
welcome.
profitable?
We're gonna have to back up a little bit because I missed one of the quality reports.
Oh, I'm sorry.
The quality improvement dashboard. We saw the first dashboard, but,
Second, looks
yeah.
like this.
I'm
It's a
sorry,
little
thank you for
more
bringing that to my
colorful.
attention.
It's titled Mineral Community Hospital Quality Improvement Dashboard Report 2013. And this is the report that the governing board sees just every quarter. And so it's current through June of 2013. There are 15 projects on there. I've also included some new data towards the bottom. I'd love it if you would take a look at those projects. I've reviewed them all with the board members once, but I'm happy to give you more information about, if the title of the project doesn't tell you what it's about, I'll tell you what it's about. And then,
So
you're
Michael-
welcome to ask me questions about the data.
The ones that have no data, is that because there were no data points or there was nothing?
Right, you could certainly go down through them one at a time. That's it. There is either no project or the QI team that is responsible for the project did not complete any work.
With regards to pharmacy, in my mind, I mean, is that a direct link to medication errors that we have on the other dash?
It's not, but the Department of Public Health and Human Services has identified that if you have a multi-use bottle sitting on a counter that has been opened and it has not been labeled with the date and time that it was opened, that it could be a contamination risk.
Sure.
And so we're trying to reduce that. And it's tough to do because we had to change. We no longer purchase multi-dose vials.
They're all single, aren't they?
We're
Yeah.
working towards that, yeah.
We're working towards that, so.
Yeah, well, you can see, well, sometimes you might have a shortage, like sodium bicarb right now is shortage. You can't buy those in single-dose vials. You have to buy multi-dose vials. And a provider does not use a whole bottle of sodium bicarb. And so it's really hard to throw that bottle away because that's money, but.
Aren't those just
you have to.
Tums?
Pardon?
Aren't those just Tums?
Injectable.
Oh, injectable, okay. Sorry.
You use it to take the sting out of.
Well, it's just a buffer.
Lidocaine.
You can't.
Yeah, you can. Yeah. So Angie Mellon is our pharmacy technician, and she's the one who does these checks for us, and she reports every month how many of these vials that she finds. And it's been a whole training thing for the nursing staff to get them to throw away a half-open bottle.
Well, what I'm looking at though, which is a positive, a very big positive, is looking at where, you know, that and the laboratory identifiers, the numbers are definitely going down, which is really a great thing. I mean, if our target is 0, it's really great to see them coming down.
You're just talking about injectables there, and you're not talking about a patient bringing in a bottle and sitting on the table or something of their own.
That's right, we're not talking about that.
Okay. The Clinical Outcomes Committee, improve compliance with ED chest pain protocol.
Mhm. Would you like a little
That's,
more
yeah, I
information
would,
about it?
that's not a very good number, and my question is whether we really are looking at, poor quality.
I'll tell you what it's about. When a patient presents to the emergency department complaining of chest pain, we assume that the worst case scenario, and so we have a protocol that's established where the nursing staff has to complete 12 steps, and our goal is to have that completed within a 10-minute time frame. And those are things that should be completed before the provider is even notified. We give the patient, there's just a bunch of things that we do, and so we felt like we were doing a pretty good job on it. We didn't have that protocol 5 years ago. And so the nursing staff built it, and we implemented it, and we practiced on it, and we were all to the point, we thought we were really kicking butt on this protocol. But we wanted to find out, and this is one of the quality indicators that the nation is focusing on. So we selected that one for our outpatient QI project. So this team got together under the direction of Wayne Holden, and there's nursing represented, CNAs are represented, lab, radiology, to actually figure out what our baseline is. And you're looking at our baseline number there. For every patient, of the 12 things that we're trying to accomplish in the 10-minute time frame, we accomplished 54% of that.
What kind of numbers are we talking about for the pool? So those 50%, 4%, are we looking at 3 cases?
10.
I mean, 10 cases,
That was 10
okay.
cases.
Why does it have to be done in 10 minutes?
Oh, it's just kind of a national goal.
Is this,
Okay.
Doing an EKG,
Who-
applying
who-
oxygen.
who determined the indicators or the criteria?
The medical staff approved them.
Yeah, there's some national data out there too. That, do you utilize that multi-state reviewing system? Because there's programs that, 1 month you'll send all your chest pains in and they're reviewed. And they look at the national indicators, like are you getting your EKG done on time? And, door to thrombolytic time and that sort of thing, and on strokes, did you have your CT? Do you?
We do it now. We started it a year ago before we even started the project, submitting that data. The problem that we ran into initially is providers weren't identifying it as a chest pain, and so we were having a hard time pulling the cases, and we fixed that. Now we're at least getting the cases to review.
That's some pretty important data there, because that is standard care issues.
And that's where I felt like I wanted to jump on this one, because I thought we were doing a great job. And we will present that to the board, and I do think on most of these, we're probably beating the national averages.
Fine.
On, like, time to EKG, time to O2 sats, time to aspirin.
The wheels are turning. I can see you thinking.
Well, I think
have-
that's kind of what we're looking
Yeah.
at. We want to compare ourselves to the nation, and we want our customers to know how well we're doing, or not.
Well, and this is important, we have to know where we are to improve, so.
Does that include the last 10 charts we reviewed, or we're meeting tomorrow again, and will we have new data then on that particular subject?
Yeah, your team reviewed those in July, so they're not
Yeah,
on this one.
right.
Okay, do we have any more questions for Kirsten? I want to keep things
Good
moving.
job.
We need to set a date for our strategic plan meeting. We've had to reschedule that. I would really, really like to get this done in September.
Yep.
And it'd be good to meet in the
And-
evening on a Friday and most of the day on a Saturday.
Yeah, and I think my personal opinion is that we need to, and I think it's become kind of pretty clear that we can't have a joint strategic planning session. We need to have, the hospital needs to have their own strategic planning session. So I don't have a calendar. Does anybody have a calendar?
The 14th is a Saturday,
The
so the 21st is a Saturday, and the 28th
Okay.
is a Saturday.
Well, we
So do
want to
we-
have it before the September board meeting.
Before the September board meeting, which is on the 25th, I believe. So Am I
We
right?
go the 21st.
There is an MHA conference.
That's, I know that there's that, I don't remember when that is.
It's the week of the board meeting, I think.
Is the MHA
Our-
conference?
Before the board meeting?
Typically in September, we've had to reschedule the board meeting because everyone's gone to that conference. So we may,
No, it's the 25th.
when is it?
The MHA conference is like the 25th through
I
the
don't know.
27th.
Yeah, it's during board meeting, I just looked at it.
So it's that week of the board meeting. It is during the board meeting.
Mhm.
Can we do a board
Is there a
meeting on
fifth,
Monday.
is there a
Thursday?
fifth, is there a fifth Thursday in September? No.
Um,
It's either that or the 3rd of October, but I don't know if you wanna go.
The health center has to have meetings in the month.
Yeah,
Could we have a
So I
board
think
meeting earlier?
that's what I'm thinking, we
Well,
might, I don't know.
The only thing that concerns me about having the meeting earlier is we just barely get the financials in time for the
Yeah.
meeting we have.
That's
If we
true.
have it
That's
earlier,
right.
we won't have the financials.
Well, could we have it like on the following Tuesday or something?
It's a different day of the week, yeah.
Of the board
Ma-
meeting?
Make
Fourth
sure we have,
Tuesday?
make sure we have ample, notice.
Yeah.
Could we move that to the evening then?
I'm fine with that. It's easier for me to have it in the evening.
Like on a,
Sorry with me.
what day?
So the
were you
24th?
thinking? The 24th,
24th is a Wednesday?
Tuesday.
I was gonna say Tuesday. I was gonna say I can't do on Wednesdays.
And then we could possibly have the strategic plan meeting on that, the 21st and 22nd, to the 20th and 21st, evening of the 20th, and then the day of the 21st. Did that work for most board members? Give us some prep time.
And, yeah. That is a Friday and a Saturday.
But how does that fit with your schedule? So are you gonna be in town and so forth?
I just have to find a babysitter. That's my only issue.
It'll work for me.
Who's
That's why I
attending
have a
this
fire.
meeting?
The strategic planning meeting is the hospital board.
The whole hospital board?
Yeah.
Yeah. we don't
Okay,
have that.
that's 20th and 21st.
That works, yeah.
It will. So it's Friday night and Saturday morning.
I know Saturday.
Friday night, probably from 6 to 8, 5:30 till.
Okay. And then our next meeting, we want to schedule that for Tuesday, the 25th? No, 24th? At like 7 o'clock. Does that work for you, Terry?
Can I ask a question about that? You schedule your meeting for them, does that mean mine starts at 11 o'clock?
No, I think it will probably have to be on different days.
No, it won't.
They'll probably just have to be on different days.
Okay. There's a point of clarification.
No, that, I was thinking about that too.
I have no idea.
You'll have to
No,
wait till
'cause the
that board
same-
meets. Yeah.
I think they would, well, and the health center board would have to address that, but I think they
Right.
probably both have to be moved if staff is gone.
Right.
I don't know,
They'll have to discuss it.
they'll have to
Yeah.
discuss that, yeah.
Did you set a time for the 24th?
7 PM.
So that's for the regular board meeting.
That's the regular board meeting. Make sure Cliff has enough time to get his financials. So, do we have any other new business? I didn't have anything. Okay, then anyone have something for the good of the order? All right. Okay, we need to move into executive session for, oh my gosh, for some personnel, credentialing, and some potential litigation.